Now today we are going to discuss about the motor system, how the movement of the body is controlled. Please remember that this is not one organ of the brain. This is in general, just like the sensory stations, we have learned how the sensations goes. Similarly, in the motor system, we will talk how the movement is controlled by your brain or cerebrum. This is a very important basic slide. And hello, can you hear me? Are you hearing me? Hello? Okay. Now this is another basic important slide to give you the concept how the movement is controlled. You know the movement of the body is done by contraction of muscles, and how the contraction is controlled, and this muscle acts on the joints, and that is how you move. How the contraction is controlled is by the higher center in the cerebral cortex. There is a motor area in the cerebrum, just like the sensory area you have seen before. This motor area is present in the precentral gyrus. Precentral gyrus. You remember sensory is located in the postcentral. This is precentral gyrus, or by Rackham it is area 4, motor area 4 in the cerebrum, located double central sulcus. That's why it is called precentral gyrus. Now the neuron is located here in the motor area. This neuron sends the fiber axon down, and this goes through the brain stem, and to the spinal cord, crosses and go to the opposite side motor horn cells. You see, this is the anterior horn, gray matter of the spinal cord, which is motor in function. This fiber ends here. There is another neuron arise from here, and it passes through the spinal nerve, ventral root of the spinal nerve, and then it go to the muscle, motor end plate in the muscle, in the different parts of the body at the different level of the spinal cord. So this is the whole pathway called corticospinal. This fiber is called corticospinal. This is the whole pathway how your muscle is controlled, how the contraction or movement is controlled. Now here you can see there are two parts of it. One from the motor area going down and ends at the anterior horn cells of the spinal cord. This is called upper motor neuron. This is called upper motor neuron. And then from the anterior horn going to the muscle, it is called lower motor neuron. Upper motor neuron and the lower motor neuron. Why I'm telling you this, because if there is a interruption or damage to this pathway, the patient will develop phallic or paralysis. There is different pictures in the upper motor neuron and the lower motor neuron paralysis. Suppose there is a damage in the upper motor neuron because of hemorrhage or degeneration or anything. The patient develops paralysis, but with the paralysis, the patient will have high tone of the muscle. Reflexes are high hypertonia and hyperreflexia, yani jerks are increased, muscle tone is increased, fee paralysis, lekin with the paralysis, there is increase in tone, there is increase in reflexes. In another condition, when there is a damage in the lower motor neuron, the patient will have paralysis, and with the paralysis there is low tone. Tone is decreased, reflexes are decreased. In this increased, we call it upper motor neuron paralysis if there is a damage here. If there is a damage here, we call it lower motor neuron paralysis. So please remember these two very important clinical pictures in the upper motor neuron and the lower motor neuron. So in the case of head and neck, you know that it is not supplied by the spinal nerve, it is supplied by the cranial nerve. And the cranial nerve has a nucleus. We divide the pathway in the case of head and neck or in case of cranial nerve as the supranuclear and the infranuclear in case of the cranial nerve or head and neck only, because head is not supplied by the spinal nerve, it's supplied by the cranial nerve. So instead of upper motor neuron in the cranial nerve, we call it supranuclear, and in case of lower motor neuron, head and neck or cranial nerve, we call it infranuclear. So the picture of the patient is mukhtalif in the different paralysis. Therefore, you should understand what is lower motor neuron, what is upper motor neuron. So this slide gives you the basic concept of the control and what is upper motor neuron, what is lower motor neuron, what is the clinical picture in this different type of the paralysis. Now in this slide, this is what we have discussed earlier. There is few neuron, the corticospinal fibers from the cortex come down to the anterior horn cells, and this is controlling the muscles in lower motor neuron. This pathway pass through the pyramid. What is pyramid? Pyramid is an elevation in the medulla. It passed through the pyramid of the medulla. That is why we call it pyramidal system, or because it is direct coming to the spinal cord and then to the muscle. We also call it direct pathway. You can see here, this is the pyramidal or direct pathway about which we have discussed in the previous slide. This is the pyramid. Why called pyramidal? Because it's passed through the pyramid. Besides this, you see here there is another pathway coming through the different stations, coming to the anterior horn cells. You see this pathway? This pathway is not direct. It passed through the many stations in the brain and brain stem. It is interrupted and mafi direct. This do not pass through the pyramid. Therefore, we call it extra pyramidal. It is indirect, extra pyramidal or indirect, and then come to the anterior horn cells and then controlling the muscle. The fiber from the neuron will come to the caudate nucleus and lentiform nucleus. Caudate and lentiform nucleus. These two nucleus in the cerebrum. Please remember their position. This together called basal ganglia. And what is basal ganglia? Mainly the caudate nucleus and lentiform nucleus present in the cerebrum. Please note it down. It is present in the cerebrum. Then the fiber from here go to the lower stations in the brainstem. Maslan, substantia nigra, aswat nucleus. Nigra means aswat, black nucleus in the midbrain. Ahmar, red nucleus. This is also in the midbrain. These two in the midbrain, substantia nigra and red nucleus. And then go to the olivary nucleus. Olivary nucleus in the medulla. Then go to the reticular formation. This is also a nucleus and the fibers together. We call it reticular formation. Reticular formation present in the brainstem. So from the basal ganglia, the fiber come to substantia nigra. It can come to red nucleus in the midbrain. It can come to the olivary nucleus like zaitun, olive, olivary nucleus. Then come to the reticular formation. Then from these stations, the fiber go to the spinal cord. Spinal cord. I have shown only one pathway, but there are from each it goes to. Muslim from the substantia nigra go to the spinal cord. We call it nigrospinal. From the red nucleus, rubrospinal. From the olivary nucleus, olivospinal. From the reticular formation, reticulospinal. Yani separately from each, it controls the anterior horn cells. And from anterior horn cells, the lower motor neuron controls the muscle. So you can say that the muscle is finally controlled by two pathways, one direct or pyramidal and one indirect through many stations. Now, why there are two systems? Basically, the pyramidal system or direct controls the big movement, course. An extra pyramidal system controls the fine movement, small or fine adjustment. So please remember, have a concept of these two, pyramidal system and extra pyramidal system. These are the basic things which I have tried to explain to you in this diagram. Please remember these extra pyramidal nuclei. All these are extra pyramidal nuclei. Remember their position, makan, where they are present. Caudate nucleus and lentiform in the cerebrum, together called basal ganglia. Substantia nigra and ahmar, red nucleus, these two in the midbrain. Olival nucleus in the medulla, reticular formation in the brainstem, and these control the anterior horn cells. So anterior horn cells of the spinal cord is controlled by the basal ganglia is in the cerebrum. So this is controlled by two systems, direct and indirect. Please make sure I have tried to, this is very complicated, but I have tried to show you in a very simple way. That is how you understand. Now we'll talk something more about the pyramidal, details about the pyramidal and extrapyramidal systems. We'll talk the pyramidal system first. I have told you what is upper motor neuron, what is lower motor neuron. Pyramidal tract first mostly consists of corticospinal fibers for the opposite anterior horn cells and also the corticonuclear fibers for the opposite cranial nerve nucleus. These fibers arise from the motor area, I have told you, and in the motor area and premotor area. In this motor and premotor area, there are large pyramidal cells, neuron. This is called bed cells. Bed cells, if I ask you, bed cells are present where? It is present in the motor area of the cerebrum. Now, these fibers pass through the cerebrum, then pass through the midbrain, crus cerebri of the midbrain, then pons, and then go to the medulla. Here you can see the fibers rising. This is the motor area of the cerebrum, the highest center, and from here you see the fibers are coming down. They collect at one place here. Gobble collection, this fiber is called corona radiata. The corona radiata fibers are converging fibers in the cerebrum. Here, corona radiata. Now when they are collected here in the brain cerebrum lower part between the caudate nucleus, lentiform nucleus and thalamus. I will tell you more about it. These three big nuclei, they are collected here. They are called internal capsule. Fibers are collected here. It is called internal capsule. Remember, this is a very important part, and I will tell you more about this in the second part of this lecture. This is called internal capsule. Internal capsule is actually the area where in brain hemorrhage most of the bleeding takes place and the patient suffers from paralysis of the body. So remember, internal capsule and the corona radiata. Then they pass through the midbrain. Then they pass through the basilar part of the pons. Then they go to the medulla. In the lower medulla, the elevation I have told you is pyramid. Now in the pyramid, lower part, it divides the fiber, corticospinal fiber in the pyramid cross. 2/3 of the fibers, 75 to 80% of the fibers cross and go to the opposite side. This is called lateral corticospinal tract. 1/3 same side. This is called anterior corticospinal. The Gobble pyramid of the medulla, it is only corticospinal tract. But in the pyramid of the medulla lower part, it divides into two. 2/3 fiber cross, make the lateral corticospinal, 1/3 not cross to the same side. So here it is, the fibers are divided into lateral corticospinal and anterior corticospinal. Anterior corticospinal uncrossed, 1/3. Lateral corticospinal crossed. And this fiber now finally go to the anterior horn cells in the medulla. motor horn or anterior horn cells of the medulla. The uncrossed fibers go down tahat, and they also cross in the spinal cord. They also cross in the spinal cord. So, in fact, there is about 100% fiber cross. In the pyramid, only 2/3 cross and 1/3 anterior corticospinal. Anterior corticospinal also cross and go to the opposite side in the spinal cord. And finally, it again comes to the anterior horn cells of the spinal cord. So actually there is 100% crossing. Yani if somebody has hemorrhage here, brain hemorrhage in this internal capsule, he will suffer the paralysis on the opposite side. So the fiber cross. So this is some details about the pyramidal system. Please try to understand this is a very common thing, and common hemorrhage takes place in the internal capsule. What is lateral corticospinal, what is anterior corticospinal, and up to now here it's only corticospinal. So this is about the pyramidal pathway. Extrapyramidal fibers. I have told you that the fibers which these fibers do not pass through the pyramid, therefore called extrapyramidal and parapyramidal, outside pyramidal. It is responsible for a smooth or fine activity, fine voluntary motor activity. I have told you already about the nucleus. Extrapyramidal nucleus are caudate nucleus, lentiform nucleus, substantia nigra, the red nucleus, olivary nucleus, all these are extrapyramidal nuclei. Now, what are the tracts? Extrapyramidal tracts. Please remember their names: rubrospinal, tectospinal, reticulospinal, vestibulospinal, olivospinal. All these 4-5 are extrapyramidal tracts. Please remember their names. Details you will learn more later. Remember names only, because sometimes we ask which of the following is an extrapyramidal tract. So you should know, or which of the following is a pyramidal tract. Please remember the names of these extrapyramidal. I have already told you about the extrapyramidal nuclei. This is the cerebrum, brain. You know that this is the central sulcus, or the Merkezi sulcus, central sulcus. And the area vara is postcentral gyrus. This is sensory in function. An area in front, precentral gyrus. This is motor in function. This is motor area. So this is just to show you the central sulcus, the sensory area vara, postcentral gyrus, and motor area with them. In front it is called precentral gyrus, or by Rakam it is area 4. Now this is another very important thing to know. This is a coronal section through the motor area, and you know that your body is represented upside down. Your head is down and the leg is forward. So this is the inverted representation of your body. This is one thing to remember. You can see here the head is tahat and other parts of the body is above. Another thing you will see here, that there are some areas which occupy a more bigger area representation. And then this number 1 is the speech area. You know, all these structures, mouth, tongue, larynx, they occupy more area in the mouth. In the head, you can see this big area for the mouth, larynx. Why? Because the speech in the human is very specialized. You can change the tinge, you can change the frequency, you can do anything you like. So this is a very specialized. Animals, Haiwan cannot do it. So this is a special area. That is why you have big area for the speech. All those structures involved in the speech, muscle, larynx, tongue, mouth, have a bigger representation. Another thing you see for the thumb, very big area. If you compare with the abdomen and lower limb, very small, but thumb is very big. Why? Because thumb is very special. highly developed in human hand. It has opponent's position, and if you remove the thumb, about 80-85% of the function of the hand is gone. So please remember these two areas, bigger representation. There are some clinical terms we should know at this stage. Hemiplegia. Plegia means paralysis, paralysis of half of the body. Paraplegia, paralysis of the lower limb. Monoplegia, one, paralysis of one limb. Quadriplegia, paralysis of the four limb. Paresis, paresis is weakness only. Hemimafi, total loss. Total motor control is not lost, see weakness only. It is called paresis. So there is a difference between paraplegia and between hemiplegia and paralysis. Plegia is paralysis. Paresis is weakness only. Another thing about the extrapyramidal, degeneration of the extrapyramidal stations, nuclei, especially substantia nigra of the midbrain, results in extrapyramidal syndrome, also called Parkinson's disease. This is because of degeneration in the basal nuclei, in the extrapyramidal nuclei. You know, I told you that extrapyramidal control the fine movement, and in this patient the patient will develop rasha, and no control over the fine movement. You might have noticed in the old age, above 60, 70, 80 years, there is some normal degeneration of the extrapyramidal nuclei. And in these patients, the old age develops the rasha. This is called extrapyramidal syndrome. There are many other features I will show you in the next. This is the common type of the problem. You see, this is the cross section, and in this cross section you can see the part of the midbrain, and in the midbrain phi aswath strip, this is extrapyramidal nuclei called substantia nigra. And in the Parkinson's disease, the substantia nigra degenerates, Mafia aswath or less. Here it is normal, here it is degeneration. In these patients develop Parkinson's disease or extrapyramidal disease, or extrapyramidal syndrome. In these patients, you have rasha, mask-like face, yani mafi expression on the face. He is happy or sad or weeping or crying, you don't know. So mask-like face. Then rasha, slow walking, short stepping gait. All these features are for the Parkinson's disease. The patient will come to your clinic, slow walking, no expression on the face, rasha. All these are the symptoms of Parkinson's disease, which is because of the extrapyramidal degeneration, nucleus degeneration. So this is about the motor system. Another part of this, we want to talk to you about the internal capsule. This is a part of the motor system, and this is very, very important because clinically this area is very important. Most of the brain hemorrhage or bleeding takes place in the region of internal capsule, and it will give you paralysis because the fibers are collected here in this region. Now, what is internal capsule? I have given you an idea. The internal capsule is a V-shaped band of fibers between thalata gray matter masses, thalata nucleus, caudate nucleus, oval, thalamus, and lentiform nucleus in the cerebrum. You can see in this diagram, this is the caudate nucleus position inside the cerebrum. This is lentiform nucleus. Lentiform like lens on the lateral side. You can remember by L. L lateral, lenti is lateral. This is medial side. In the medial side, phi caudate nucleus. Then the thalamus. You know about this nuclear mass. It is a sensory station, but it is a nuclear mass. The band of fibers, henna, collection, many fibers. Here it is called internal capsule, like a V. This is the shape of the internal capsule, V-shaped. Now in this internal capsule, there are parts: anterior limb, genu, which means a bend, posterior limb, retrolenticular part, yani varalenticular nucleus, and sublenticular, tahat lentiform. These khamsa part or 5 parts here you can see. Anterior limb between the caudate nucleus and lentiform nucleus. Then the bend is called genu. This is the posterior limb. This is the sublenticular part, and this is the retrolenticular part. And now you can see this is the anterior limb, this is the genu, this is the posterior limb, this is sublenticular, this is retrolenticular. Please remember the parts of the internal capsule. Again, I have in this diagram you can see the parts more clearly. Anterior limb, genu, genu is the area of bend, posterior limb, retrolenticular part, and sublenticular part. Again in this slide you can see the anterior limb, genu, posterior limb. Anterior limb is present, makan, present between the caudate nucleus and lentiform nucleus. Posterior limb is present between the thalamus and lentiform nucleus. This we ask sometimes, anterior limb is present where? Between what? Posterior limb present between what? So this is the area of internal capsule, fibers. In this diagram, you can again see this is the area of internal capsule. The fiber arrives from the motor area, go down, isthmus corona radiata, and tahat, they are collected. It makes the internal capsule. This is the area of internal capsule in the cerebrum. This is the frontal lobe, occipital lobe, corpus callosum, septum, but concentrate here in these structures. This is the caudate nucleus, lentiform nucleus, thalamus, anterior limb, genu, posterior limb, retrolenticular part, and sublenticular part. There is another strip here, gray matter, lateral to the lenti. Lateral to the lenti. This is called claustrum. This is also a part of the extrapyramidal, but less significant. Claustrum, a gray strip lateral to the lenti. So this is the position of the important structures inside the cerebrum. Now what is more important is what fiber pass through the different area. Maslan, what fiber from the anterior limb, what fiber pass through the genu, what fiber pass through the posterior limb. It has importance because if the hemorrhage is localized in one area, it will be affecting the same fibers. Maslan, number 1, anterior limb, please remember number 1 only. I will tell you only number 1. If you remember, that is sufficient for you. Don't go into the other smaller nucleus, smaller fibers. This is anterior limb. Remember anterior thalamic radiation. Number 1. Only 1. From the genu, number 1, corticospinal. Corticonuclear, I'm sorry. Corticonuclear fibers. Maslan, if I ask you, if there is a hemorrhage or bleeding in the genu area, which fiber is affected? Corticonuclear, for the cranial nerve nucleus. From the posterior limb, remember 1, corticospinal. Corticospinal. So remember, if I ask you, if there is a hemorrhage, bleeding in the region of posterior limb, which fiber will be affected? Corticospinal or pyramidal fibers. Don't bother about the smaller corticopontine, corticorubral, superior thalamic, and fibers from globus pallidus, etc. This I show you the fibers from the different region. From the retrolenticular part, you have posterior thalamic radiation, that is optic radiation. So remember awwal only optic radiation. If I ask you there is a hemorrhage in this region, which sensation will be lost? Optic, vision. Similarly, sublenticular part, auditory, hearing. If there is a hemorrhage here, auditory fibers are damaged, which results into the loss of hearing. So please remember number 1 from each part. This is again the same actual diagram of the brain cerebrum, horizontal section. This shows you the caudate nucleus, lentiform nucleus, thalamus, and you can see the internal capsule, anterior limb, genu, posterior limb, retrolenticular part, and sublenticular part here. So this is again the same. This is the frontal lobe, this is the occipital lobe, temporal lobe, and like that. I have told you the clinical anatomy of the internal capsule is very, very important because the brain hemorrhage takes place mostly in the region of internal capsule. A patient who is old, 60, 70 years, he has a history of hypertension, he is normal, but suddenly small artery in the region of internal capsule ruptures and makes bleeding, hemorrhage, and the fibers in internal capsule are damaged, and you examine the patient, half of the body is paralyzed. This is a very common representation, hemiplegia on the other side. Why? Because of the bleeding in the region of internal capsule, which commonly we call it brain hemorrhage or cerebrovascular accident. Brain hemorrhage in common language results hemiplegia. Here you should remember, because the fibers are crossed, if there is a hemorrhage on the left side, the paralysis will be on the right side. If there is a hemorrhage on the right side, the paralysis will be on the opposite side. So please remember, this is the commonest clinical problem. Here is the area of internal capsule. You can see the hemorrhage in this region. Hemorrhage or bleeding in this region. So this is all about the motor system and the internal capsule. These two are very important. Maybe in the next